Hello from the south coast of England, where I'm delighted to be able to share some of my thoughts on human milk banks globally, but also specifically on the advantages of ensuring multi-sectoral collaboration in their planning and development. I have no conflicts of interest to declare other than that I work in the field of human milk banking. And also that I've contributed to the work of both Alive and Thrive and PATH, which are NGOs that I refer to several times in this presentation. So first of all, a definition of a human milk bank. It's rather a long definition, but I like to use this one because it includes some of the additional points that most definitions don't include. This definition comes from the organisation PATH. So a human milk bank is a service responsible for the recruitment of donor mothers, the collection, screening, processing, quality control, storage and distribution of donor human milk to meet the specific needs of infants and young children in a health establishment or community for whom donor milk is needed while protecting, promoting and supporting breastfeeding. Why human milk banks? Well, it's a fact that in spite of optimal support for mothers in the first hours and days of their new baby's life, there will inevitably be some for whom their own mother's milk is either insufficient or not available. Now, we should of course do everything we can to minimise the number of these infants, but for those who fall into this category, especially if born early or of low birth weight, the WHO recommend donor human milk as the supplemental feed of choice. They further recommend that it be obtained from an established human milk bank, as this is known to be the safest option due to the rigorous donor screening, milk testing, and thermal processing and so on. What is less widely discussed globally is the need for multi-sectoral collaboration when developing the milk bank, together with integration into existing nutrition and newborn care services. When in place, together, these will optimise the equitable and the safe provision and use of the donor human milk. So here's another definition, this time donor human milk, which is milk expressed by a lactating mother that is then processed by a human milk bank for use by a recipient that is not the mother's own baby. Straightforward enough. Very importantly included in this definition is that payment for the donated milk is not provided. Very salient part of that definition. And looking also at a human milk bank's mission, which is to promote and support breastfeeding by providing safe, high-quality donor milk to address gaps amongst those who would not otherwise have access. So, in other words, donor human milk is a bridge to breastfeeding, or for some infants it may be their only opportunity to receive human milk. In answer to the question, why donor milk? Well, it prevents the long-term use of IV nutrition, or the sole use of IV nutrition, which can lead to some well-known health impacts such as liver disease and increased infection rates. More frequently, it can help to avoid the use of formula, whilst providing many of the immunoprotective and the bioavailable components of human milk, even though it's usually been frozen at least twice, as well as heat treated. Very importantly, we know from studies across the world that the availability and the appropriate use of donor human milk will promote breastfeeding. However, there are some caveats to this, and I've listed them, a few of them here. Firstly, that its use should be integrated into a feeding regime that facilitates the closest possible contact between parents and their babies. And it should contribute to the infant's optimal health and nutrition. Its use should never undermine family-centred care, but should always support lactation and breastfeeding. To ensure all of these, it's clear that milk banks should work hand in hand with, or indeed be an integral part of, local, regional and national breastfeeding support services. So with these thoughts in mind, here's a map taken from the Path Resource Toolkit for establishing and integrating human milk bank programs. The map is interactive and clicking on a dot will bring up details of that human milk bank. And here's a link to all the Path milk banking resources. The map shows the current global provision of donor human milk being made available via around about 750 human milk banks in over 60 countries, and which is feeding annually at least 800,000 infants, although the latter is very much an estimate as many milk banks and hospitals don't yet make this data available. Milk banks follow guidelines that have been developed locally in the light of national and international guidelines. And some of these are available freely to download from the associations that publish them. And although they have much in common, there are also distinct differences according to the model of milk banking that is being followed. And you can see here that these differences include who the donors are who provide the milk, who the recipients are, the criteria for recruitment and screening of donors, how the milk is tested, heat treated, the equipment used, and so on. It's worth noting, I think, that there are no global standards, at least not yet. Policy leaders globally, including from WHO, have contributed to the development of PATH publications, including the toolkit that I mentioned, which contains 11 core documents and which recommends multi-sectoral input into the development of all milk bank services. It's also important to state that many milk banking models that are currently operating illustrate the need for minimum standards to take into account the very different availability of resources and funds. So one size fits all is definitely not a maxim that should apply to milk banks, whether in the context of actual facility size, operational size, or indeed size of equipment. A small-scale human milk bank can operate just as safely as a large regional service, as long as the underlying principles of risk avoidance, risk management, integration into optimal feeding practices are followed, and there is input from the many services that are involved. And these include neonatology, of course nursing, midwifery, microbiology, nutrition, infection control, lactation support, pharmacology, health promotion, and so on. I'd also like to add that education and training are key to safe milk bank services, and all who work in the bank should be supported to learn the essentials of quality control and assurance, in addition to the rationale behind all the tasks that they perform. So whether the milk bank is a standalone service in support of a single hospital neonatal unit or a local community-based unit, an example of this was the first milk bank in South Africa, which was established on behalf of a small home that was caring for babies who had been abandoned or orphaned as a result of HIV and AIDS, or whether it's a network of nationally organised and funded banks supporting all the hospitals in the country, as in Brazil, or all the models that lie in between, the underlying principles will be the same. And recognition is needed of the importance of working with all the stakeholders and actively collaborating to integrate the milk bank into the wider provision of breastfeeding support and infant nutrition. Successful milk banks, in my opinion, cannot work in isolation. So you will see from the map that there are parts of the world with only a few, if any, milk banks, and other regions with very many. But the numbers are only half the story because of the different models. For example, in North and South America, the ones in the south are mostly serving single facilities, whereas those in the United States are the opposite. They collect and send milk across at least several states, often many more. Similarly, in Europe, very different models have developed over the past 100+ years. The UK is a very good example. So, Scotland in the north of the UK has a single bank that serves the whole country, whereas England has 15 that differ um, from single hospital banks to regional services. And the Hearts Milk Bank, uh, which provides donor milk not only to hospitals over a large region, but also to many babies in the community whose mothers are ill and cannot feed, largely as a result of undergoing cancer treatments, although there are other rationales for this as well. So all of this has developed as a result of collaborations with supporters from many different sectors. However, sadly, in England, unlike Scotland, there has yet to be a national service, and equity of access is yet to be achieved. In Africa, as you can see, there are not many milk banks, although actually there are rather more than illustrated in South Africa. I believe there are actually about 30 now in South Africa. There's also a very well established human milk banking association in South Africa. Otherwise, on the continent, there's a newly developed and established milk bank in Nairobi, in Kenya. There are some very, very small milk banks operating in a few hospitals in Cameroon, and over to the west of the Oval, on the island of Cape Verde, there is a milk bank there that's very much linked to and follows the model of the milk banks in Brazil. Moving further east, in India, the Ministry of Health has been instrumental in driving forward a national growth in milk banks with the vision of creating at least 100 as a means of supporting the health of newborns. The milk banks are integrated into hospital-based breastfeeding support and lactation management services. Australia now has an emerging national service, as well as several banks that have traditionally provided milk to just one hospital. Throughout Southeast Asia, there are examples of all the different models of milk banks, and the region is the centre of a very active collaboration across many of the different countries. And looking more closely at Southeast Asia, there are clear examples of the benefits of a multi-sector approach. And banks across the whole region have been working together to develop minimum standards, as well as to support the countries that are developing their first milk banks, so Indonesia and Malaysia. So teams are able to make visits to their neighbouring countries to learn firsthand from their experiences. The Milk Bank Association of the Philippines, with its extensive expertise, has provided much support across the region. And they're also able to share their experience of providing donor human milk in times of natural disasters and emergencies, where rapid working with relief agencies is also necessary. The team in the milk bank in Singapore have worked with local religious leaders to ensure milk banks and the donor milk they provide is acceptable to the Muslim community, and a resultant fatwa has proved invaluable in enabling the milk bank to operate safely and in accordance with religious requirements. Focusing on Vietnam, which has benefited from financial and practical support via both Alive and Thrive and PATH, and as a result has been able to strategically develop an initial service that has since been expanded to meet the demand from other areas, as well as be a model that can be replicated elsewhere in the country. Now, this happened recently when the second bank was developed in Ho Chi Minh City at the Tudu Hospital. The Vietnam Milk Bank experience is the best example I know of multi-sector planning and development and oversight, and in collaboration with Alive and Thrive has led to a learning and research centre for newborn care and access to human milk, which is based at the Da Nang Women and Children's Hospital. Happily, their progress has all been documented and can be used by all who want to learn from their experiences, as the documents are all available to download from the Alive and Thrive website. The PATH resource toolkit includes a readiness tool that identifies the first steps in establishing a bank. In fact, it suggests actions that should precede the decision to develop one. So number one is who to include in the leadership team. So it needs to be able to provide multifaceted and multidisciplinary leadership, and so should ideally include expertise from national, regional and provincial ministries or departments of health, from hospital management, from any regulatory authorities, from the field of quality control as well. Input from neonatal, paediatric and nutrition societies is needed to ensure the service will meet the perceived need, and a health economist can offer sound financial advice. Relevant religious considerations are also best included at this early stage. Together, the team should first be tasked with assessing if a milk bank is actually needed in the first instance, or if other steps should be taken to improve provision of mother's own milk. The team will then gather data on the need for donor human milk, who will provide the milk, so who the pool will comprise, the donor pool, what existing policies are in place that will impact on any decisions being taken, and these can refer to Sustainable Development Goal indicators, for example, or available national health data. Local leadership and support can be garnered at this stage. Essential infrastructure, staffing requirements, and building a network are all important initial stages. I've also added here, recognise the clinical, practical and ethical implications of introducing donor human milk into feeding regimes. And there's more information on this poster that I wrote a couple of years ago, which I'm happy to share the PDF of with anyone that would like it. So do email me or ask me for it in a question. The final few slides relate to the impact of the emergence of the COVID-19 pandemic on the work of human milk banks. As expected, it led to challenges in donor recruitment and screening, the transportation of milk, its safe handling and contingency planning. I assumed these challenges were being faced by all milk banks around the globe, and so took the step of creating a virtual network which quickly grew and now includes over 100 members from over 40 countries. It's a virtual network. We gave it the tentative title of GAMBA, the Global Alliance of Milk Banks and Associations. So it, as I said, now includes over 100 members from over 40 countries. Collaborative working began very quickly within the group, which provided an easy and ready means of communication. Dr. Natalie Schenker, my co-founder and the director of both the Hearts Milk Bank and the Human Milk Foundation, has been the instigator and the main author of several publications that have resulted from the group's collaborations, including the first one which appeared in the Lancet Adolescent and Child Health Journal in May, and which documented how milk banks globally were maintaining safety and service provision, as well as being a call for action in response to the pandemic. A plus from the development of the group was that we were able to come together very quickly to celebrate the World Day of Human Milk Donation, an event originating from Brazil, but which had never actually been globally celebrated. If you follow the link at the top of the slide, you'll find the video of our Together We Can celebration, in which over 150 photographs were taken of milk bank teams and individuals in the group who shared their visions of collaborative working. So an album of all the photos was created, and it's being made into a book because the messages that were received, as I said, over 150 of them, were truly inspirational. A further paper will be published soon, and we're looking at ways to best develop the virtual GAMBA group into a more formalised community that can be the biggest example yet of bringing together the global expertise from many different disciplines that can best inform the future of milk banking and, very importantly, the future of donor milk support for infants wherever it's needed, and can together create a global milk bank movement in support of breastfeeding. So thank you for your attention, and I shall look forward to your questions. Bye bye.